Hello and welcome to Health Professional Radio. I'm your host, Neal Howard. Thank you for joining us today here on the program. Our guest is returning to speak with us, Dr. Ann O'Donnell. She's the Division Chief of Pulmonary Medicine and Critical Care and Sleep Medicine, and she's also the Medical Director of the Sleep Disorder Center at Georgetown University. And she's returning to talk with us about some late-stage options for those who are suffering with NCFB. Welcome back to the program, Dr. O'Donnell.
Thank you.
Thank you. Now, we were here before talking about NCFB. Could you give us a little bit of background about yourself and tell us what NCFB is?
Sure. NCFB is Non-Cystic Fibrosis Bronchiectasis. So basically, it's a term that describes the clinical syndrome of bronchiectasis in patients who don't have it due to cystic fibrosis. I've been doing research in this disease for a number of years. It's a relatively low-frequency disease, but something that's being recognized with increasing numbers of patients in the U.S. and really worldwide, probably because the disease is actually increasing in frequency and also because we have better tools to confirm the diagnosis.
Is there a place or one specific location, either in the United States or, say, worldwide, that seems to be more susceptible for cases of NCFB?
You know, in the United States, it does appear to be something that's found in all 50 states, but there are certain hotspots, for example, Hawaii, and also coastal U.S., both East and West Coast seem to have a higher prevalence of this disease. And then around the world, really Asian countries have, and really Northern and Southern Europe are also areas where this disease is seen with some frequency.
And do you think that you mentioned coastal areas having to do with the moisture in the air or anything like that, maybe complicating what is already, as you described in other segments, as a disorder or an abnormality that seems to be genetic?
Yeah, no, some patients have it for genetic reasons, but many other patients have this disease for reasons that we can't diagnose or we don't actually know what triggered it. Probably the most common cause is some sort of infection several years prior to the onset of the bronchiectasis. But it does appear that the infections that complicate bronchiectasis may have some predisposition for areas with higher humidity, so hence Hawaii and coastal East Coast, West Coast in the U.S.
Does this respiratory disease have any links or sometimes leads to any types of cancers in that area as far as lungs or the bronchial tubes or trachea is concerned?
Really, as far as we know, this is not a disease that predisposes patients to cancer. So that's the good news. It's a chronic disease, cough and mucus production, but not something that, as best we know, really leads to any sort of malignancy.
Now, you mentioned that this disease is becoming more prevalent, more recognizable. Do you think that there's some reason that it has become, of late more noteworthy than before? Are people starting to come forward more, or more diagnoses being made? What do you think?
Yes, we don't really know the answer to that question because bronchiectasis is a disease that's been around since the time of Hippocrates. So people have recognized it for years, but since the 1980s in the U.S. at least, there's been this increase in the diagnosis. So it may be that it truly is increasing in frequency. There's also easier ways for us to diagnose it, mainly the CT scan, and hence I think there's just more diagnosis because people are having more CT scans of their chest. So it's a combination of things.
Now, this is a fairly rare chronic respiratory disease. What are the numbers that we're talking about here?
Well, we think in the U.S. it's at least 100,000 patients, and to put that in some perspective, there's about 34,000 patients in the U.S. with cystic fibrosis. So, although it's relatively rare, it's more common than some of the diseases that most people have already heard about. And there's probably large pockets of patients that have some bronchiectasis that have not been truly identified as having the disease.
How much are you involved in getting the word out about NCFB out to our caregivers who may not be familiar with it at all?
Yes, it's interesting that at medical meetings, particularly in the world of pulmonary medicine, there's been increasing focus on this disease, so that we're trying to get the word out to our colleagues who practice pulmonary medicine. We also have several colleagues in our world of research in this disease that are infectious disease specialists, so trying to get the word out about how to deal with the infectious complications of bronchiectasis to the ID population of physicians. And, getting it out to the primary care physicians has been an important, though a little bit more challenging aspect of teaching about this disease.
Is this something that, if identified early, can result in a lot less flare-ups, a lot less discomfort and inconvenience, as opposed to dealing with it for, I guess, several years? Are there late-stage options, and are those options significantly different than the options available once it's identified early on?
Yeah, that's a great question. Is early diagnosis and early treatment going to alter the natural history of the disease? And honestly, we don't know that simply because we don't have sort of a lot of information about how this disease progresses. It's a very heterogeneous disease in that some patients are diagnosed with some bronchiectasis on their CT scan and really never progress, whereas other patients, particularly if they get infected with bacteria like Pseudomonas or non-tuberculous mycobacteria, do progress over a relatively slow progression for most, over 10 to 20 years. But we do think that early diagnosis and early intervention probably helps, but honestly, I can't prove that scientifically.
So what are some of the best late-stage options for relief?
Yeah, so in terms of late stage, it's, again, really key to know what the bacteria are that are affecting the bronchiectatic airways. And so we really emphasize that doing sputum cultures, both for routine bacteria and for other infections like mycobacteria and even fungus, are real important. And hence, then you can target antibiotics aimed at those bugs. Some of the other things in later stage disease that we might consider include surgery, particularly if there's one lobe or one relatively contained part of the lung that's primarily affected. And in the worst case scenario, even lung transplantation, but that's rarely needed in this disease.
Is someone who is eligible for a lung transplant, are they less eligible because of NCFB? And if they're getting a lung transplant for something else, is this something that's going to complicate it, or is it something that can be treated along with the other situation that's being addressed?
So doing a lung transplant for non-cystic fibrosis bronchiectasis is akin to doing it for cystic fibrosis. It's just that many fewer patients will be eligible for lung transplant because this is a disease of more the older population, and hence, the older group of patients is not eligible for transplant because of their other comorbidities. The type of infection that our patients get also might influence the potential for being transplanted. Because if they have a very resistant bacteria in their lungs, that usually precludes getting a transplant.
When we're talking about infections, when it comes to the immune system, does our body try and combat this disorder from now on with antibodies or any other immune defense system, or is this something that has to be enhanced with treatment? 100%.
So there are some patients with this disease who actually do have deficiencies of their immune system. That's rare. It's probably less than 10% of the bronchiectasis patients in the U.S. actually have an immune deficiency that can be treated with immune globulin replacement, and that would help them fight this. But most patients with bronchiectasis do not have a problem with their immune system. If anything, the immune system's somewhat revved up. But that isn't enough to, counteract the effect of the infections, and then you really need to focus on the antibiotic treatment aimed at the particular infection that the patient has.
Now, where can our listeners go and get some more information about some of these late-stage options for treating NCFB?
Probably the best places, although the coverage is quite general, is by looking at the NIH website. The National Heart, Lung, and Blood Institute has a website about bronchiectasis. There are some websites from the Mayo Clinic and National Jewish Health. Our research group, the Bronchiectasis Research Registry, which is part of under the aegis of the COPD Foundation, also has a website. Health professionals should look in the NIH's PubMed for review articles, because there are quite a few on this disease that I think are quite helpful as well.
Well, thanks for talking with us today, Doctor.
Okay, thank you.
You've been listening to Health Professional Radio. I'm your host, Neal Howard, in studio with Dr. Ann O'Donnell. She's Division Chief of Pulmonary Medicine, Critical Care, and Sleep Medicine, also Medical Director of the Sleep Disorders Center at Georgetown University. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. You can subscribe to this podcast on iTunes and listen in and download on SoundCloud.